Mona?
Hello, everyone. My name is Mona Lutfi. I am an infectious disease specialist working at the front line to treat and prevent HIV and hepatitis C in Toronto and Saskatchewan. I am a professor and clinician scientist at Women's College Hospital and the University of Toronto, and I have the pleasure of being your moderator today. I welcome you to the second installment of the Canadian webinar series on implementing the WHO Guideline on sexual and reproductive health and rights for women living with HIV. This webinar series is a collaboration between the World Health Organization's Department of Reproductive Health and Research, CHIWOS, which is the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, the Canadian Positive Peoples Network, Oak Tree Clinic at the BC Women's Hospital, Women's Health and Women's Hands Community Health Centre, the Canadian Aboriginal AIDS Network, and the IBP Initiative, alongside many other partners across Canada. It is a pleasure to work with a broad range of committed people and organizations. I now have the pleasure of asking Kerrigan Beaver, as a First Nation person from this land, to officially open our webinar with words of welcome and remembrance.
Ani, Indigenous Cause Kerrigan. I am a two-spirited Anishinaabe Clay from Couchiching First Nations. My spirit name is Lightning that dances across the water. I am from the Eagle Clan. I want to welcome you to this webinar, and in keeping with Indigenous protocols and building respectful relationships between Aboriginal and non-Aboriginal peoples in Canada, it is customary to acknowledge the traditional territories, ancestral lands of Aboriginal people. I would like to acknowledge that this webinar is situated upon traditional territories, and these traditional territories include the Wendat, Anishinaabe Nation, the Haudenosaunee Confederacy, the Mississauga, the New Credit First Nations, and the Métis Nation. Slide.
Next slide.
I'd like to take a moment to remember the participants that are no longer with us and who have moved on to the spirit world. As of this morning, we remember 50 women. They will be forever in our hearts and their families and friends in our prayers.
Next slide. Thank you so much, Kerrigan. Such an important way to start this webinar. At our first webinar, Dr. Angela Kaida reviewed that about 1/4 of those living with HIV in Canada are women, meaning that approximately 17,000, maybe now 20,000 women are living with HIV in Canada. One of the most important experiences for women living with HIV is HIV disclosure, for many complex reasons. Let's begin with a definition. HIV disclosure is defined as the process of telling someone that you are living with HIV. That can be a family member, friend, colleague, healthcare worker, stranger, sex partner. That experience can be voluntary, but it can also be involuntary. There's much to consider when disclosing one's HIV status, mainly related to stigma, discrimination, and fear, with significant potential impacts also and related issues, including self-worth, worry, stress, issues of criminalization, depression, isolation, trauma, violence, and other experiences that are listed there, and much more. Next slide. In 2013, we carried out a cross-sectional survey with close to 2,000 women living with HIV in 4 regions of the world. We found that while 89.4% had disclosed their HIV status, very few, only 4.5%, had fully disclosed their status, and that the degree of HIV disclosure correlated with quality of life. Next slide. As you can see today, we have several objectives, which you can see on this slide. All of these objectives are important, but I want to stress the final objective, which is to collate the 4 presentations from these webinars including the discussions that we'll be having at the end of each one, and the priorities that we identify as a group, and to draft a national action plan on sexual and reproductive health and rights of women living with HIV in Canada. Next slide. Like our last webinar, since you can't actually see the webinar speakers, we have provided their photos here. Here they are, an incredible, intelligent, powerful, and effective group of women leaders. Next slide. A brief overview of our agenda. We will begin, like last time, with Dr. Manjula Narasimhan from the WHO, then Dr. Angela Kaida and Miss Valerie Nicholson, who were our moderator last time and our elder from the first webinar, will present a research overview of HIV disclosure and related issues for women living with HIV in Canada using CHIWOS data. Then we will proceed to presentations on implementation projects related to HIV disclosure, where we will hear from 3 speakers, Miss Jasmine Cottenham from the Canadian Aboriginal AIDS Network, and Miss Marvelous Machenje and Miss Sandra Godoy from Women's Health and Women's Hands. Then we have reserved 20 to 25 minutes for discussion and questions, and we want to hear from you about this topic and about developing an action plan. Finally, we will close and discuss next steps. Next slide. Okay, ready for some housekeeping information. During the presentations, please submit any questions using the text feature on the application. I'm sure many of you have used that before. Presenters will ask questions during the discussion session at the end of the webinar. Our team will collate the questions and ask them to the presenter on your behalf. If you are joining us by phone, please send any comments or questions by email to our Ontario coordinator, where I'm located, because she'll pass on the questions to me, and there is her email address, so please write it down. If we do not manage to address all the questions during the webinar, the organizing team will collate the questions and send responses to all the webinar attendees after the webinar, like we did in the first webinar. Questions and answers will also be posted online with the recorded version of the webinar. Please type any technical difficulties that you're having into the text feature. This webinar will be recorded and posted on the IBP channel and the WHO Reproductive Health Research YouTube channels. Links will be posted at the end of the webinar. There are handouts that you can download from your own viewing, for your own viewing and reference. If there are any references and tools that you would like to share, please send them to Becky Gormley, who's the coordinator who's been organizing all of these webinars, and we'll be posting her email at the end of the webinar series. Next slide. On behalf of today's presenters, we do not have any conflicts of interest to declare. On that note, let's get started. It is my pleasure to introduce our first panelist, Dr. Manjula Narasimhan from the WHO. Manjula, please go ahead.
Hi. Hello, everyone. Thank you so much, Mona, and thank you to all the speakers for the second webinar in this series that form part of the efforts by the World Health Organization to disseminate the guideline on sexual and reproductive health and rights of women living with HIV. An overview of the guideline is available from previous webinars, and so I won't be going back in detail on that overview. And the overview includes in-depth information on new recommendations as well as good practice statements, and links to the guideline is also available on the handouts included on the right-hand panel. I want to remind everyone that this is a global guideline that is focused on healthcare settings and it pertains to the sexual and reproductive health and rights of women living with HIV in all their diversity. Next slide, please. I also wanted to remind everyone of the framework used in the development of this guideline, which places the key principles of a woman-centered approach, gender equality, and human rights at the center. And health interventions that you see here in blue and the safe and supporting enabling environment that you see in purple are both important to provide women living with HIV high-quality health care. Next slide, please. So I just wanted to show the recommendations here related to the topic at hand of this webinar. We know that experience or fear of violence is a barrier of HIV disclosure, accessing treatment and care services. And in the development of this guideline, 2 new recommendations have been developed, specifically around supporting women living with HIV who are considering HIV disclosure but may fear violence or may be experiencing violence. The results from a global community survey, which we have also previously described, and as well as global statistics, have highlighted that violence experienced by women living with HIV is significant. And the violence experienced by women living with HIV occurs at many levels, from intimate partner violence, sexual violence, in relation to family and neighbors, the community, in institutions, but also in healthcare settings. And the first webinar we had covered some of these topics. So these 2 new recommendations that are included in the guideline are aimed to raise awareness, provide guidance for policymakers, and describe actions that can be taken by healthcare providers on the issue of safe disclosure of HIV status for women living with HIV. As this is a consolidated guideline, it also includes existing recommendations, such as those that you see on this slide in relation to adolescents or support for couples and partners. Next slide, please. So the recommendation also builds upon previous WHO guidance on violence against women and girls. On this slide, you see some of the existing guidance and clinical handbooks from WHO. And current WHO recommendations include that healthcare providers should ask about violence to women based on signs and symptoms or conditions that are likely to complicate or underlie intimate partner violence. That healthcare providers should offer at a minimum first-line support if they're not able to, and if they're not able to do so, refer to someone else in their setting or elsewhere that's accessible to, who can provide such support. So a lot of these recommendations are already existing for interventions addressing violence. And therefore, action on the recommendations in this guideline for safe disclosure requires strategies that are not only informed by evidence and existing guidance, but are appropriate to the local context, and is also responsive to the needs and to the rights of the women living with HIV themselves. WHO is now following up on the development of a manual for healthcare providers and a training curriculum for both in-service and pre-service training for health providers, and we're hoping to develop a specific component for providers to support women experiencing violence with safety in relation to HIV disclosure. And the feedback from this webinar is very important so that we can build upon the evidence, build upon your experiences and your input. On this slide, I also have included the name of Avni Amin, who is my colleague in the department, who many of you know is working on issues related to violence against women and girls. You can contact her directly for further information on this. I really look forward to your thoughts, to your feedback on how best we can implement the guideline on sexual and reproductive health and rights of women living with HIV, and very much look forward to the feedback from this webinar. Thank you.
Thank you so much, Manjula. Next slide. It is my pleasure now to introduce Dr. Angela Kaida and Miss Valerie Nicholson, both from Vancouver, British Columbia in Canada. And Angela moderated the last session, as I told you before, and Valerie opened and closed our last webinar. They will give the research overview. Angela and Valerie, please go ahead.
Wonderful. Thank you so much for the kind introduction, Mona. Next slide, please. We would like to begin by acknowledging and thanking women living with HIV, our partners, our communities, our funders, and the many organizations and individuals who support CHIWOS and make this research possible. Next slide, please. We also honor and remember each of the now 50 women living with HIV who participated in CHIWOS from across Canada and who have passed away. Next slide, please. When women with HIV can safely disclose their HIV status, including informed choice about to whom they disclose, for whom they disclose, and when, where, and how they disclose, evidence suggests that disclosure is associated with improved HIV care outcomes. And this includes fewer barriers to accessing HIV care, improved ART adherence, better quality of life, and reduced HIV transmission risk. Supporting women to disclose, however, must be contextualized within a woman's life, as there's also substantial evidence showing that disclosure can lead to more violence, fear, relationship disillusion, abandonment, and aggravated experiences of HIV-related stigma and discrimination. Women's concerns about and experiences of violence are particularly well documented now. In our previous webinar on trauma and violence-aware care, we described that 80% of women living with HIV in Canada have experienced violence in adulthood. So violence both compromises ability to disclose and can be manifested through the experience of disclosure. And in Canada and other settings where not disclosing HIV status can be criminalized, there are additional expectations, barriers, and consequences to disclosure. Next slide, please. As a brief overview, in October 2012, the Supreme Court of Canada ruled that people living with HIV can face charges for failing to disclose their HIV status to sexual partners prior to sex that poses a realistic possibility of HIV transmission. The legal obligation to disclose is based on a legal interpretation of HIV transmission risk, regardless of whether the transmission actually occurred or whether there was intention to transmit. And this duty to disclose is averted only in the case of condom-protected vaginal sex with low HIV plasma viral load. There are no HIV-specific laws in Canada, so sexual assault laws are most commonly applied in cases of HIV non-disclosure. And conviction of the charge aggravated sexual assault can result in imprisonment and mandatory registration as a sex offender. And our evidence reveals that legal and social expectations of disclosure are not gendered, and despite a presumed intention, do not function to increase disclosure in practice, nor increase safe sex practices. Next slide, please.
Expectations of HIV status disclosure exist within a context of widespread HIV-related fear, violence, and stigma and discrimination, augmented by gender and relationship power inequities. You can see the numerous ways that social and legal expectations compromise our health, our safety, and our rights. Women living with HIV prioritize protecting those around us, even though we are the ones at risk and under surveillance. We are too busy protecting our families and our children to protect ourselves. We are already living with the stress and stigma of HIV, and expectations of disclosure completely fail to recognize the world we live in. The addition of surveillance and criminalization serves to make our lives more difficult and our health worse. Currently, the emphasis is on protecting everyone else from the women living with HIV. But who is protecting her?
Next slide, please.
Next slide.
Thank you. Despite the increased gender consequences of disclosure for women, as outlined by Val, a study by our team, which enrolled both men and women living with HIV who use injection drugs, revealed that women are less likely to meet the legal criteria for non-disclosure, that is, using condoms and having a low viral load, and are thus twofold more likely to face a legal obligation to disclose their HIV status to sexual partners compared with men. Next slide, please. So given the social and legal expectations of disclosure for women living with HIV in Canada, we sought to answer two key questions. The first, how prevalent are worries about disclosure? among women living with HIV? And the second, are women living with HIV aware of the current legal expectations of disclosure? And relatedly, do they have the information that they need and deserve about the law in Canada? Next slide, please. Briefly, in terms of methods, we use survey data from the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, or CHIWOS, which is the largest community-based cohort study of women living with HIV, trans-inclusive, in Canada. We enrolled 1,422 women living with HIV from 3 Canadian provinces, British Columbia, Ontario, and Quebec, with 18-month follow-up visits. Grounded in principles of critical feminist theory and community-based research, CHIWOS involves women living with HIV and allied clinicians, researchers, and community members as core partners throughout all stages of our research. Next slide, please. To share some of our results, you can see presented on this slide responses to each of the 5 items of the validated HIV/AIDS targeted quality of life, or the HAT-QOL instrument, which is the disclosure worry scale. For each of these items, women are asked how much they agreed or disagreed with each item. And you can see in the bars represented here that 31% of women reported that they agree or strongly agree to being worried about losing her source of income if other people find out that she has HIV. 40% are worried about her family members finding out that she has HIV. 56% are worried about people at her job or her routine daily activity finding out that she has HIV. And 68% are afraid to tell other people that they have HIV. And nearly 75% of women report limiting what they tell others about themselves. Next slide, please. And we did further analysis of this data to show, to identify what we called high disclosure worry, or a score greater or equal to 75. And found that high disclosure worry varied significantly by several social and clinical factors, as you can see in this bivariate analysis. So high disclosure worries were more prevalent among women living with HIV in Quebec, among African, Caribbean, and Black women, younger women, women more recently diagnosed with HIV, and women who were not receiving HIV medical care. Next slide, please. So to shift quickly to our second objective, we also asked women about their awareness of HIV non-disclosure laws in Canada. You can see the question we posed here. And after asking this question, the peer research associate interviewer provided a concise and accurate definition of the most recent case law, regardless of whether our participant reported that she was aware of the law. But among those who reported being aware, we asked them, how similar is this definition to what you understood about HIV disclosure and the law in Canada? Women who said that their understanding was the same were considered as having an understanding of the law. Next slide, please. So as shown here, of women enrolled in CHIWOS, 73% reported being aware of the 2012 Supreme Court ruling on HIV non-disclosure. However, overall, only 37% of women were both aware of the ruling and had an understanding of the legal obligation to disclose. Next slide, please. And in our adjusted analyses, both awareness and understanding of the law varied by several social and clinical factors. In general, women facing multiple forms of social, economic, and structural marginalization were less likely to be aware of the law, including African, Caribbean, and Black women, women with less education, detectable HIV viral load, unaware of HIV prevention benefits, and those reporting high HIV-related stigma. Importantly, women who were engaged in HIV work in their communities had higher adjusted odds of awareness of the law. Next slide, please. And lastly, we asked women about their perceptions of available supports for HIV disclosure in the climate of criminalization. And you can see here that irrespective of their awareness of the law, women express high levels of trust in care providers, believe their information is kept confidential, and report that provider-led discussions on HIV disclosure are very important. Critically, however, only 42% of women overall reported being satisfied with HIV disclosure support services. Next slide, please. Our findings here highlight that many women living with HIV in Canada express substantial worry about disclosure, and such worries vary by markers of social and clinical vulnerability. And although women are less likely than men to meet the legal criteria for non-disclosure, only 1/3 are aware of and understand the law. And women who know less about the legal requirements to disclose include women who are less engaged in HIV care and who experience violence and other forms of oppression. And women do express a willingness and desire to receive information on disclosure in the law from providers, and they want to engage in a safe way. But they report that current HIV disclosure services are insufficient. Next slide, please.
Women are falling through the cracks. We need women-centered services to support safer HIV disclosure. We need enabling environments to support safer disclosure. This includes reducing stigma and ending the over-criminalization of HIV non-disclosure. Supporting sexual and reproductive health and rights means ensuring that women are leading disclosure decisions, not risking forced disclosure or having their status disclosed on their behalf. Next slide. This research was conducted in response to a call for action from CHIWOS peer researchers and participants, and this topic remains a considerable concern for many women living with HIV, both in Canada and internationally. Meaningful involvement of women living with HIV is an important part of this research to ensure women's experiences are accurately and sensitively represented. The advancement of community involvement in dialogues around HIV disclosure and the law is critical to empower community leadership in this field. Next slide, please. I would just like you to think about how criminalization can change our lives. We as community and researchers need to listen to women's voices. We must involve women in the research process to honor their unique perspectives gained by living under surveillance in the current legal climate. Our voices are powerful, and speaking out is how we make change. We need to educate our community about the law, to encourage women to make safe choices about when and how to disclose, and how to lead safe sexual lives with the freedom and rights that all members of society are afforded. Next slide, please. I would like to close by sharing this powerful quote from Louise Binder with you. She says, "It's a terrible irony that we have come to a place where the medications we fought for will allow us to live in a relatively normal quality of life, and now we are going to go to jail for doing so." Next slide.
Next slide, please.
And here are all our references for today. Thank you.
Next slide.
For more information, it's on the slide. Thank you.
Thank you very much.
Thank you so much, Angela and Valerie. Those were incredible data and presentation, and so important. Now we will move into the series of presentations on implementation. We will begin with Ms. Jasmine Cotnam from the Canadian Aboriginal AIDS Network. Please go ahead, Jasmine.
Hi. Good afternoon, everybody. So yes, my name is Jasmine Cotnam from the Canadian Aboriginal AIDS Network. I hold the position of the Aboriginal person living with HIV/AIDS liaison. I'd like to acknowledge the Canadian HIV/AIDS Legal Network, as well as the Canadian Aboriginal AIDS Network, as I have the pleasure, and next slide please, of speaking to the Indigenous communities and HIV disclosure to sexual partners guide that was created in partnership. You'll see a link here that is that you can click on to have access to the PDF version of this. Goodness, I've just lost my screen. Bear with me. There we go. Okay, and I'm just going to kind of continue on. Bear with us. We've lost the screen and it's back. Wonderful. Okay. I know we need this. Okay, so thank you. Okay, so we're going to talk about disclosure to sexual partners, and I've taken this from the pamphlet that was created. So because HIV can be transmitted during sex, the criminal law in Canada imposes an obligation to people living with HIV to share or disclose their HIV positive status to sexual partners in circumstances. And I'll speak more to that in a few moments. To date, more than 180 people have been charged in Canada for not disclosing their status to a sexual partner. Next slide, please. So, quoting a very brilliant friend of mine, Jan Tickner, HIV thrives where social injustices live. In Canada, Indigenous people, especially Indigenous women and youth, are disproportionately affected by HIV It is estimated that in 2011, Indigenous populations represented 12.2% of all HIV infections and 8.9% of people living in Canada. Indigenous populations are extremely diverse, with communities that reflect variations in historical backgrounds, language, and cultural traditions. In their diversity, these communities are more affected by HIV because of a variety of factors and social determinants of health that influence vulnerability to HIV infection, including poverty, housing, and homelessness, as well as early childhood development, physical environments, access to healthcare services, support networks, and social environments, gender, violence, and incarceration, as well as racism and the multi-generational effects of colonialism in the residential school system. Next slide, please. So let's just talk a little bit about what is disclosing to a sexual partner. It's in informing a possible sexual partner that you are HIV positive. This person could be anyone from whom you have or want to have a sexual relationship with. This could be your spouse, a regular sexual partner, or someone that you plan on having sex with just only once. Next slide, please. And what the law means. There's a duty to disclose before any sexual relations that pose a realistic possibility of transmission. Individuals are not required to disclose their HIV status before having sex if a condom is used and an HIV positive person has a low viral load. In one of the decisions, the court considers that an HIV viral load of 1,500 copies of the virus or fewer, I'm sorry, I have a bad slide there, of blood to be low. Next slide, thanks. So telling others that you have HIV, or that you are HIV positive, can be difficult and stressful. That has been actually pointed out in the two previous presenters. They may be afraid of rejection, violence, discrimination, and having your confidentiality breached. These concerns are real life for people who are living in tight-knit communities and where communities where sexuality and HIV are taboo. Racism, gender norms, economic conditions, and cultural and language barriers are all factors that can affect a person's ability to disclose their status. Take precautions to reduce risk of HIV transmission and access support. So the suggestions that have been given are to contact your local aid service or organization as a first step to finding support. There are also a number of health organizations and Indigenous communities that you can contact, such as CAN, where I work. And you may also want to seek legal advice deciding whether or not to disclose your HIV status. Next slide, please. So HIV is a legal term. You know, I've never actually used that term in my life ever when telling somebody something really personal and private about myself. You know, I may want to tell somebody, hey, this is a story or a part of my life that I want to share with you. So I'm self-identifying as a woman, an Indigenous woman who's living with HIV. Disclosing basically means that I'm trying to keep myself safe from being convicted or charged or have any involvement with the law regarding telling somebody about a very personal part of my life. Sharing is something entirely different. Next slide, please. So, although there's a lot of great support and literature out there for HIV disclosure, like the Indigenous communities and HIV sexual disclosure to sexual partners, as well as information that's come out by very many different organizations, please remember that as long as stigma exists, it's a lot harder and more complicated in real life to share your status with somebody that you're living with HIV. Miigwech.
Thank you. Thank you so much, Jasmine. That was really powerful. I really liked your description of the difference between disclosure and sharing. I just wanted to remind everyone who's joining us, the audience and the attendees, that you can actually start to send questions right now in the application on the side, anytime, so that we can start collating them. So if you have thoughts or questions, please go ahead and send them in the application or by email. So now it brings me great pleasure to introduce our next speaker, Ms. Marvelous Mchenje. Please go ahead, Marvelous.
Hi everyone. Thank you, Mona, for the introduction. Are you hearing me?
Yes.
Okay. So my name is Marvelous. Today I'm going to share with you some of the reasons why women actually disclose their status or sometimes hesitate to disclose their status. Next slide. So discussing HIV serostatus disclosure is critical, yet we find that it's challenging for both service providers and also women living with HIV. And most people living with HIV are usually willing to disclose their HIV status to their significant others in their lives. But then I think people might ask, so why don't they? Next slide. Some of the reasons why women sometimes do not disclose their HIV status is because there's a greater risk in losing either their family, friends, job opportunities, or just the security of just feeling that you are your emotion, you're stable because of what might happen afterwards when you disclose. Also, the reality when you disclose to people, things start falling apart. And for some, if you are migrating, you're an immigrant and you're depending on someone else to actually be applying your application for you, and you don't know the rules and regulation of that country, you might fear that once my status is known, I'm not going to have my papers in that country. Next slide. And so some of the facilitators that I've seen for women who disclose is maybe it's because they just want to break the silence. They're tired of giving different reasons of why they're sick. And sometimes it's just for a request for prayer. They've been sick for some time, and then they think maybe someone told them that there's a healer who can actually heal them after they pray for them. And sometimes they just need support from others. And we've also seen that just knowing that the other partner that you have in your life is also HIV positive encourages women to disclose their status. And also with prevention to further transmitting either vertical transmission or transmission to another intimate partner. Next slide. So in one of the interviews that was done by Ontario AIDS Network, when they were developing a booklet with words from people living with HIV and what they think about disclosure, one of the participants said, when I disclose, I feel like a flower, vulnerable and exposed, but powerful. Next slide. And someone also said, you get peace of mind when you disclose. You own your story. You don't continue living under a veil of secrecy. Storytelling encourages the hearts of others to receive your disclosure. 1 minute you have control and then you don't. I sacrificed myself by disclosing to save my community. It was worth the personal risk. When I looked at these words, of course some of them are so encouraging, but the words like I sacrificed, I have control, just shows that it takes so much courage for one to actually disclose their HIV status, whether it's to a family member or just the community. Next slide. So when we asked women also in one of the projects that we are going to talk about in just a few minutes, some of the women identified that they use different strategies in disclosing. Sometimes it's just point blank, where you didn't plan it and then you just disclose your HIV status, or it's partial disclosure, bit by bit and incremental, depending with the situation. But sometimes also for some women it was involuntary. They didn't plan to disclose their status, but someone else actually did that for them. And I've seen a lot of that on Facebook or in there's so much now media that you find that if one knows the status, anonymously they spread it in the community. Or sometimes it's accidental. It just happened and people got to know about it. And service providers also sometimes just disclose your status, even if at the reception at the clinic, or when you go for visit, then they just assume the people that you are with know that you are HIV positive. Next slide. There's laws surrounding HIV disclosure, and I think also some of it has been covered, and we've seen that also a lot of fear and just an inconsistency in the what is required is also impacted on the HIV disclosure. And the laws at first were meant, they looked like they were protecting women, but in reality we've seen that they are not actually protecting women. They're actually leaving women vulnerable. We've seen cases where women go and report an abuse case, and they end up being the ones that are being charged for HIV non-disclosure. Next slide. So there's so much work that is being done also in North America, because that's an area where there's also high rates of cases that we are seeing criminalizing, including criminalizing women. So a group of us that included academics and people living with HIV attended a training academy that was held in Alabama in 2016, and it was a wake-up call because we realized there's so much work that was being done in US in terms of advocating, in terms of bringing people together, that when we came back to Canada, we decided to also join forces as Canadians at a national level. And the purpose for that coalition, which is called Canadian Coalition to Reform HIV Criminalization, was to reform discriminatory and unjust criminal and public health laws and practices that criminalize and regulate people living with HIV in relation to HIV exposure, transmission, and non-disclosure in Canada. Since the formation, this group has done a lot of work. Is still ongoing. We are based in different communities, so we are able to collect cases that are happening within our communities and also provide support to people who are in prison. Next slide. And we also currently previously there've been consensus statements that have been developed by doctors, and also people living with HIV have also developed some consensus statements. And recently there's one that has been I think we'll be able to share that one with you, that is also circulating, and we're seeking signatures calling for various actions by federal, provincial, and territorial governments to address the overly broad use of criminal law in cases of alleged HIV non-disclosure. And most of the cases that we are seeing also, no transmission was evident. And also sometimes we know now with U equals to U, undetectable equals uninfectious. There's so much now that people living with HIV can use as an armor to fight against the laws. And I'm also part of, together with some of the ladies that are on the call, for a project that we call Women, Art, and Criminalization of HIV, which is WATCH. Unfortunately, sorry, I forgot to put the link. We've done body mapping work where women living with HIV share their stories on how it impacts them. And we also held a previous roundtable in violence against women, and this roundtable we're actually also highlighting how the law impacts women living with HIV. So we're glad that this is working. We still haven't got where we want to be, but at least it's brighter. The sky is looking brighter, because at least with the Minister of Health, who with the Minister of Attorney General, who at World AIDS Day also highlighted the impact of the criminalization of HIV, we know it's going to happen. Thank you. Next slide. Thank you so much.
Thank you so much, Marvelous. That was a great presentation. Now it brings me great pleasure to introduce Ms. Sandra Godoy from Women's Health and Women's Hands to talk about a model for disclosure. Please go ahead, Sandra.
Hi, I'm so happy to be here. as one of our first presenters was talking about, women feel the need to have service provider-led discussions on disclosure, and there is a bit of a gap in terms of the support. So I'm glad to be talking about this model. The aim of this model is to provide a systematic way of supporting people living with HIV through the process of disclosure. We recognize that everyone experiences disclosure differently. However, most will undergo similar stages of disclosure each time the disclosure process is initiated. I like to think of the model as a template for service providers that outlines the stages involved in the HIV disclosure process. It looks at how to explore the challenges, barriers, and possible strategies. The measure of success for this model is the engagement in HIV disclosure conversations. Our end goal is not necessarily disclosure. What we take as a measure of success is that individuals are engaging in a conversation where they're able to talk about their HIV disclosure in a safe space and decide whether or not that's something they want to do. We have several guiding principles and frameworks that led the development of our HIV disclosure support model. So when it was first created, it was created for African, Caribbean, and Black women in Toronto. And that's why the feminist and critical race perspective was so important when we developed the model. We also use other frameworks such as transnational perspective, where we understand belonging, living, and feelings of being connected to more than one place, impacting how disclosure journey might unfold, as well as JIPA and MIPA and MIWA, and a person-centered approach. So we believe that in this model, an individual has autonomy and the right to determine the action plan in the HIV disclosure journey. And in this model, we look at an individual as a whole. We don't want to reduce people to their status. There's so much more, and something we always hear in the community is that a lot of women feel that they're more than their status and they want to be treated that way. And this model really takes a look at different facets of each woman's life. Next slide. There has been about 8 years of research, so I'm just going to quickly summarize how we've got into this point. There was 3 major phases in research, and it was development, the pilot testing, and expansion. In the development phase, we did a literature review to see what was out there in terms of support models and strategies to support individuals wanting to disclose their status. We also did focus groups with women who had and had not disclosed their status, as well as focus groups with service providers who worked with African, Caribbean, and Black women. At this stage, we developed a model, and in the second stage, we had to determine whether or not it was effective. So in our pilot testing phase, we recruited 28 women, and 22 women went through the process, and they participated in about 8 to 10 sessions with their service provider and a peer support worker. At the end of the pilot testing period, we found this model to be very effective, and through conversations with our partners, there was discussion as to needing to see if it was effective for other populations. So as I mentioned earlier, we created it for African, Caribbean, and Black women, and through the expansion phase and the help of our partners, we were able to hold focus groups with heterosexual men, gay men, or men who have sex with men, as well as youth and individuals in rural communities. And we found that this model was also an effective way to provide support for anyone thinking of disclosing their status. Next slide. I'm very excited today. After 8 years, this is the first time we will be having a website. So if at any point throughout the presentation you want more information, please go to HIVDISCLOSURE.CA. Here you'll find a lot of useful resources, and I'll walk you through some of them. So if you see this first arrow, the red one, there's guidelines for organizations. So if you are part of an organization, or you think your organization would be interested in providing this model as a support service, there are guidelines that would walk you through how to do this. And then if you're a service provider who is just looking to see the model itself and wanting to have an idea of how to integrate it in your own individual practice as well, you can go to the green arrow that says support model. This one got cut off, but underneath these 4 tabs, what you would see on our homepage is you can download our workbook. So if you don't want to go online all the time and you'd like to just download an entire toolkit and print it, that option is also there. So this is a screenshot of our homepage, and I really welcome you all to visit HIVDisclosure.ca. If we can go to the next slide. So if you click on the support model, it will take you to this view, and to continue to just see the model itself, you need to click on structure and elements. That will take you to our next slide, which is the model itself. So now I'm going to spend a little bit of time talking about what this model is. So first and foremost, the idea is that this is to help someone through voluntary disclosure, and it was created with a disclosure in mind to a child or a partner. And the idea with this model was that service providers would work with individuals who wanted to disclose their status, but at the same time, a peer support worker, someone living with HIV, would also provide services and support as well, because throughout our studies, we found that the type of support that a peer can provide is fundamentally the most important for people living with HIV. I'll be giving this presentation from the perspective of a service provider, but I'd like you to keep in mind that the idea is that there would also be support from a peer throughout. This model has been used, and it was created with the idea of single sessions in mind, but lately we've actually been seeing a lot of our partners using it in a group format. So if that's something you'd like to think about, think of how you could possibly do this, and think of this as a roadmap into how to potentially structure groups. As you can see, there's various arrows, and I'll go through each individually, but I want to bring attention to the fact that it's not a linear process, so individuals can enter at any stage, and sometimes they might even move back and forth. It's not something that necessarily is, oh, you know, you did stage 1 in one session, so now we're going to stage 2. It's really a roadmap that's meant to be very fluid and flexible to meet an individual's needs. Next slide. So at the start of the journey, before we even talk about disclosure, one of the biggest pieces that we've been trying to do, and one of the biggest messages we've been trying to promote, is oftentimes the disclosure conversation starts right as soon as someone gets their diagnosis. And what we try to say is that an HIV diagnosis can bring up a lot of different feelings. And we want service providers and society at large to really start questioning, you know, is that the moment that we need to start the disclosure conversation? Or can we give an individual the space to hold their feelings, understand where they feel, what this all means to them, and then begin contemplating whether and how they would like to do disclosure. So that's how we really start this model, asking the question, is disclosure necessary? And that's a question that will come up time and time again throughout the support model. So if an individual deems that they would like to disclose their status, then we would begin the model. So if we go to the next slide, step 1 is acceptance and empowerment. So this one is really can be a lifelong process, but the idea is that before we can talk about disclosure, we have to grant the time and the space for an individual to accept an HIV positive diagnosis and adjust to being a person living with HIV, and allowing an individual to take the time to understand what this means to them. Next slide. Step 2 is about education and preparation to disclose. So there's various levels, knowledge of HIV, so understanding where an individual lays, but also taking the time to have just a general conversation about HIV and understanding the comfort level of discussing HIV/AIDS. Because if an individual has trouble discussing HIV/AIDS to another individual, we can't have the expectation that necessarily that they'll be comfortable to disclose their status. And as a service provider, the importance of mapping out different services for an individual that they could possibly get connected to at this time. And still, if you look at step 1 and 2, we haven't really started to talk about disclosure yet, but it's in step 2 that we start talking about the general potential repercussions of disclosure and non-disclosure. And this allows for some trust and relationship building to occur before we dive into the individual sentiments about disclosure. So if we go to the next slide, step 3 is where we start talking more so about the individual's life and trying to understand their motivation to disclose. So having the conversation as to whether an individual feels they want to disclose for the need to access resources, and understanding that that disclosure would look different than potential other ones, understanding whether or not it's due to a sense of personal responsibility or driven by legal obligations. The law makes it very confusing for women to understand under what situations they need to disclose and not. So having the space to talk about that will really set the tone for the rest of the model. And again, the question of is it necessary and is it voluntary comes up. We don't want anyone to feel coerced in receiving disclosure support or in their disclosure process. So that question is something that we keep in mind. In step 4, we talk about the disclosure environment. So it's evaluating evaluating the physical environment where disclosure will take place. And we use the term physical environment loosely. It also involves determining the social support that's available to the individual and taking the time to look at whether or not the safety and well-being of the person who's looking to disclose would be affected by disclosure, meaning taking the time to look at whether or not the disclosure would threaten their safety or welfare of them or their family, whether or not there's a possibility of violence, stigma, rejection, or family problems, and looking at how culture, community, faith, and social networks could impact their disclosure environment. And it's really about assessing whether or not someone feels safe disclosing their status, and in the event that they don't feel safe, what can be put in place to allow that safety to come naturally. Step 5. And this is where we talk about assessing potential outcomes for the individual themselves. What are the potential reactions to disclosure in the individual's lives? And this leads us to one of the most important questions and I think messages of this model in considering disclosure. Do the benefits outweigh the risks associated with disclosure? And that's something we try to go throughout this model, because at the end of the day, in some cases, the benefits do not outweigh the risks, and we have to respect that decision that an individual makes. And asking that question allows an individual to decide for themselves how they feel and how they think their future might be affected, whether or not they feel their health and well-being would be affected, or their family. And what we're trying to do is encourage women to disclose, but in a safe way, if that's what they feel they want to do. And really, ultimately, we can't promote or encourage disclosure if we're not ensuring individual safety. So if at this point a woman wants to continue with the disclosure plan, we would ensure that a safety plan is in place. And that would take us to step 6. So this is really about the who, where, and when, but also we take some time to look at, if someone goes through with the disclosure plan that they have, who will support the person that's being disclosed to in the immediate and in the long term. Also, part of the disclosure plan is looking at what mechanisms will be followed in the case of negative impacts. Step 6B, and if we reach this point, then we would go through with the disclosure plan. And if not, we sometimes revisit steps. What we find is some people will disengage at step 5 to re-engage in step 6 a couple months later. But the idea really, again, is just engaging people in the conversation of HIV disclosure and giving them space to really contemplate what disclosure means to them. And then if the disclosure plan actually happens, then it's a matter of debriefing possible next actions and developing strategies in case after disclosure someone else discloses on their behalf, and providing support past the disclosure. Next slide. What we've found is that people who have gone through the experience really felt that they were heard. For example, so here we have some experiences. All issues have been encompassed and listed. It was like you knew what I was feeling and what I was going through. Another woman said, thanks to all the organizer and all those who have helped me walk this journey. It was life-changing. And once again, thank you for helping me to go into the unknown. So I know I went through that really quickly. I just want to thank everyone who is on this webinar, and this is all of our partners if you were curious. And I'd also like to thank all of the women that have been involved and all of our participants that have been involved in this project and this program. And I strongly recommend you visit HIVDisclosure.CA if you want more information, and feel free to contact me if you have any questions. Thank you so much.
Great. Thank you so much, Sandra. What an incredible tool. And I do have to say, as a HIV physician, I have used that tool in my practice, and it's very useful. So now I'm really excited because we have close to actually half an hour for our discussion period. And questions have been coming in, so please send them in. We're starting to group them. I'd like to thank all the speakers for their excellent presentations. Let's give them a virtual round of applause. Please continue to type your questions, and some have already started coming in. One question was whether we'll provide the link of where this great webinar and webinar series, it will be recorded, so that you can send it to others. Yes, that link will be sent to all those who are registered, and it's right there actually, and will be easily accessible. In fact, when I went on, you can find them even on YouTube, so they'll be easily accessible. So another question that I will try to answer quickly, and maybe Marvelous or Angela also have the answer to this. It's about what percentage of women versus men are charged or convicted with HIV non-disclosure. So in Canada, like many other places, there is a gender and racial bias for HIV non-disclosure charges, and it actually it leans towards more men being charged and more African Caribbean Black men being charged and convicted in Canada. So it's about 80% are men and 20% are women. However, maybe I can ask Angela Kaida to expand on why there is a difference for the charging and conviction of women, and then maybe also Marvelous.
For me, I'm not sure about the exact percentage, but what I know for sure is some of the cases for women, sometimes you find that we don't get to read them mostly. What tends to come up in the media in terms of numbers is men who infect white women largely in most cases. But we've been seeing a lot of women being charged, Aboriginal women and other like marginalized women and sex workers, but I don't have the exact percentage. And some of the cases end up being like tried to be women are remanded in court, but then it gets settled in other ways. But I'm not sure about the exact number.
Okay, thank you, Marvelous.
Can I add to that?
Yes, Angela.
Oh, great, thank you. So Marvelous, thank you so much. That's perfect introduction. So I'll just point everybody, there's an excellent report by the Canadian HIV/AIDS Legal Network that summarizes the number of people who've been charged in Canada, and their current number is 184 people living with HIV charged with HIV non-disclosure in Canada between 1989 and 2016. That report's on their website, but as part of our feedback from this webinar, we'd be happy to send around the link or the PDF to all of the attendees, because it does a really, really good job of presenting that information and showing that It's about 88% of people who are charged are men, and about 10% are women. And then the remaining small percentage, the gender of the person is unknown. And like both Mona and Marvelous have already said, it is a very, the distribution of people who've been charged is very inequitable and very disproportionate to what the epidemic looks like in Canada. So most of the people who've been charged have been Black men, heterosexual men. And so that feature of criminalization in Canada, I think, is really important. And I'll just say that even we tend, in addition to thinking about the number of women who've actually been charged, we also think about and are concerned about what it means to live under the threat of criminalization or the shadow of criminalization. And a lot of the work that we've been doing, that's so much of what women talk about. So they talk about how, or they have questions about, if I'm facing sexual violence or I'm being, I'm sexually violated, what is my responsibility around disclosing in that context? Can previous partners who may want to use information to harm me in the future, can they use this information to do so? So it's really thinking about criminalization in its shadow and its broader effect and its threats. I just wanted one quick thing to add to that is that I think in many ways people perceive the law in Canada as being about protecting women maybe from acquiring HIV, but we really don't have the evidence to show that the law is working in that way. And rather what our research is showing is that women living with HIV are protecting themselves from the law. And so I think that is the context that also concerns us. Thank you.
Thank you, Angela and Marvelous. I'll direct the next question to Valerie. Valerie, how are we going to change our messaging so that women understand their rights and responsibilities? What are your thoughts about that? That's a big question.
Thank you. It is a very big question. I think, first of all, we need to educate positive peoples and our allies so that we're using the JIPA and the MIWA principles. And then we can educate our peers, because that's where the trust actually begins, is with our peers. And peers have to take the lead in getting that education and getting it back into community. And we have to make sure that we all have the same message, and it has to be accurate. And education has to be from a reliable network, like our allies, like Michael Vaughan here in BC. And we also need to disclose that we're not a lawyer, but we have legal allies to support our messaging and our work. And my first question should, and I think it should be for everyone, is if someone is giving you some information on this, ask them, where did they get that information? Did they get that information from a cop, or did they get it from a lawyer? And hopefully they got it from the HIV Legal AIDS Network. So whenever I present, I always encourage people to seek answers to legal questions from the HIV Legal AIDS Network.
Thanks so much, Valerie. I know that we're talking a lot about HIV non-disclosure criminalization in this webinar now, because it is such a big feature of HIV disclosure in Canada. We purposely wanted to really concentrate on the HIV disclosure part rather than the criminalization part too much. So I'm going to move on to some questions to Sandra. And please send in your questions. Keep sending them in. They're excellent. So Sandra, one of the attendees wanted to say that you presented very exciting information on the HIV positive, seropositive status disclosure support tool and model. And I would agree with that. But the couple of questions to you, Sandra, are what would be needed to use this model and tool in other countries, particularly like countries in Africa, Asia, or Latin America? And then also, if it's okay to ask you two questions, what has been the most positive result from implementing the disclosure model within the communities that you serve?
Okay, thank you. So the first question, what would be needed? So I would recommend I highlighted a section on our website where you can download the workbook in its entirety, but there's a certain part that says guidelines for organizations. So, and although the question may have had an international organization may not have had one, but what's really great about the toolkit is it outlines step by step what someone who would want to provide this model would need to take into consideration. So we have a tracking tool where it asks a lot of questions like, do you have a private space where someone could come in to talk about this, yes or no, and then what the possible implications would be if the answer was no. The questions last, I think we have about 50 questions for organizations to think, and it allows them to answer yes or no and then determine what their next steps would be. So I think that would probably be the starting point, but I'm also really open to assisting in any part of that and answering any questions, but I think that would be the starting point. And I didn't mention that in the presentation, that the guidelines for organizations really gives a step-by-step questionnaire as to what to think about when wanting to provide this support service. So that would be the starting point. The second question about the most positive result that I've seen, for me, and this is just because it's the most recent, I think, was seeing this model facilitated in a support group way. And what we did was, it was a mixed group. So there was men, there was women, and of various sexual orientations, of various ages, of various experiences with HIV and length of HIV diagnosis. So it was really amazing to see these group of people come together, and really the learning was happening from each other. There was very little that needed to be done from the service provider sense, and the atmosphere of seeing that they were just so happy to have this space to come together and really just talk about HIV disclosure, and as a group go through their questions together. I think that was really one of the more recent and exciting things that I've seen happen because of this model.
Thank you, Sandra. So in terms of using the tool in other countries, you're recommending to go to the website. Would you make the tool, are the tools, what is it called when they're protected, or are they free for anybody to sort of use, and could anyone take it and modify it? Is it okay to use and modify for the different contexts around the world? What are your feelings about that?
I think that was the intent. So it is a PDF version, but if at some point it needs to be changed to speak to the reality of people living with HIV in a different country, my sentiment is that our team would feel okay with that, because at the end of the day, what's most important is providing the support. So we are okay with someone looking at the tool and then perhaps modifying it to meet their needs in their country.
This is Wangari. Mona, may I say something?
Of course.
This is Wangari Sarao, and I work with Sandra and Marvelous at Women's Health and Women's Hands. And it has taken us 7 to 8 years to actually finalize this model. So anybody who wants to use it can actually use it, as long as you acknowledge the source of the model you are actually using, and if you modify it, you can, acknowledging that you actually got it from somewhere, and it has listed the people that have developed it. Acknowledging that would really be appreciated. I would also like to answer the question around how other people can use it, in addition to looking at the questions that organizations need to be able to answer to prepare to use the model. We also had a training program for people or for service providers that are interested in the model, and the training was 3 days you know, going through the model, going through scenarios, and trying to deal with issues that emerge and the questions that service providers have. So there's a training component to the model, but I guess organizations can do whatever it is they want to do. If you're an individual organization, you may not have the budget for a training. Try and figure out what are the important pieces. The other pieces that is really important is the question around, as you use the model, what would happen if the person you are supporting actually got charged? So you need to put in mechanisms around protecting both your legally both your providers within an organization, as well as protecting your clients, that eventually they don't get charged, because the law still remains the same. So you always have to be vigilant around what is it, you know, how do you protect everybody who is involved in that process? And because we have learned through experience how important it's actually to be able to do that. So all our lessons and all our experience in the last 7-8 years have actually been incorporated in the model to ensure that people don't experience the challenges we experienced as we developed and pilot tested and implemented the model. Thanks.
Great. Thanks so much, Wangari.
Can I add one quick thing? I think as the research team who developed this model would also really love, just out of general interest, to know if someone did adapt it and gave us credit, what they were doing with it. I think that would be really great for us to know how it's being used elsewhere as well. So I think that's what we would ask for, credit, and also just to know what people are doing.
Sure, and knowing both you, you, Sandra, and Wangari and Marvelous, you'd be happy to support them.
Yes.
So I'm going to ask the next question to Angela Kaida. Angela, I didn't hear too much in the talk, but what do you find the link is between HIV disclosure and violence in Canada? It's a big feature of the recommendations, the WHO new guideline on sexual and reproductive health and rights of women living with HIV. So what do you feel is the experience and the connection between HIV disclosure and violence in Canada?
Thanks, Mona, for such a big and interesting and really important question. So I think, you know, in Canada, we do have the research showing that women who are experiencing violence, if we understand that to be you know, intimate partner violence or gender-based violence, experience of that sort of violence really does compromise women's safety or ability to disclose. It makes it very challenging to disclose. And we certainly have research documenting that direction of effect between violence and disclosure. And on the flip side as well, we have a lot of evidence to show that the experience of disclosing HIV status can manifest more. In my presentation, I called it more violence, because it might be new violence, or it may increase the frequency or the effect of the violence. So we really have this two-way relationship between violence and disclosure of HIV status. And I think, you know, other forms of violence, we really need to think of that here as well. So other forms of structural violence. So for instance, women who may be living in poverty, may be addressing substance use issues, maybe struggling with mental health, and not getting the support that they need to do so. Those are forms of structural violence that similarly make it difficult to disclose and make the process of disclosing potentially very dangerous for them. So I think, just to summarize 2 points, that we do have this sort of bi-directional relationship between violence and disclosure, and really thinking about violence as being partially about the intimate one-to-one type of violence, but also larger environments that propagate violence against women.
Okay, thank you so much, Angela. I'll ask the next question to Manjula. Manjula, do you feel that what's been presented today in Canada is applicable to the rest of the world? What is your opinion about what we've presented and the experience in Canada? Is it helpful to the WHO guidelines and what's happening in the rest of the world regarding HIV disclosure and violence?
Thanks for that, Mona. Can you hear me?
Yep.
Yeah. Okay. Yeah. That's a really important question, and I think, as I said earlier, we are looking at examples, at best practices from different contexts to try and pull it together to make sure that an implementation of the guideline and implementation tools that we develop really are relevant to the different contexts. And I think the key principles that have been described and the examples that have been described are really relevant to for many settings. I think that we're going to need to develop. We're hoping to develop an implementation tool around this issue that we will test in other settings and see whether there may be a few things to tweak. But I think what you've shared here really outlines a lot of the key principles and a lot of the best practices that we need to make sure are heard and get used elsewhere.
Okay, thank you, Manjula. That's exciting to hear. Marvelous, a question for you. What impact is the community-driven U equals U having, or could it have, on disclosure and criminalization? Could the impact be positive or negative? What are your thoughts?
I think as a person who coordinates a group of more than 300 women living with HIV from marginalized communities, I've seen a divided stance. So some women are really receiving it positively, saying, now I feel free that once I educate my partner that they are not going to be infected, I don't have to keep the secret to myself. And then we have the other ones who would say, yeah, I know about you because you, but then if someone goes and charges me, still my name will be in the paper because the people who are criminalizing us do not understand that. So sometimes it's not that issue that you've transmitted HIV, it's just the issue that you didn't disclose your status to someone. So that's the stance that women have. And but also, it's getting more women to understand also, like, what does undetectable mean. So they are going more to look for information. What does it mean? And some are even going to have those conversations with their partners. Some are taking their partners to their doctors. So it has actually also created a way of communicating and disclosing to partners. But they know that, now there's statement, there's advocates out there indicating that I'm not infectious. So it's both positive and also sometimes negative in different situations.
Okay, thank you, Marvelous. Just a quick question for Sandra and Wangari. Are your tools and models available in French as well as in English? What about other languages? Are there plans for translation?
Not for the time being. We just have the tool available in English. We would love to have them translated if we could get the resources to do it. And hopefully that is an idea we can actually put on the table and see how we can, particularly translating it into French, because we do have French is one of the official languages, but also we do have women who speak French, but also particularly because we would like to use the tool across the country. And the largest number of women next to Ontario actually live in Quebec. So it's really important to actually translate it into French if the resources are available.
Great, I see an action plan item already. Okay, and our last question now is for Jasmine Cotnam, and then we'll move on to discussing next steps. So Jasmine, your talk was very important and interesting. I particularly liked when you shared about your experience. So can you tell me, how do you think we can maybe make disclosure or sharing, as you mentioned it, one's HIV status more of a positive experience for women?
Well, first and foremost, I would think it would be eliminating the obligation to disclose. You know, that's always being told that you have to do something to keep yourself safe from prosecution, probably, you know, puts a little bit of a negative tone on that. Well, not a little bit, a total amount. In regards to making it a positive sharing experience, I think it would be somehow to inform community of the progress in HIV care. I know that when I speak to a lot of people, the information that got out in the late 80s and early 90s has really stuck with people. And just to, like myself, being in Toronto today, I happened to be downstairs at a train station, and there was a billboard about medications and undetectable and all this good stuff, and maybe to get that into some smaller communities to open up conversations. So the conversation doesn't have to be a fear-based conversation, but more of a information and sharing and caring, and also opportunities to have family and friends be open to those conversations so they can advocate for you as well.
Thank you so much, Jasmine. That was a great way to end. So in terms of our next steps, first of all, I'd like to thank all for participating and for your insightful questions and valuable feedback. A reminder that if we didn't respond to your question or comment, we will do so after the webinar. We will post the recording of the webinar alongside the panelists' response to the questions at the links from before. In terms of the next steps, as we mentioned, we are developing a Canadian action plan to address the sexual and reproductive health and rights for women living with HIV, including priorities highlighted from this webinar on supporting safe and HIV disclosure. Please join our third webinar, Save the Date, and it is on reproductive health, rights, and justice. We believe that it's going to be on Wednesday, January 24th, and so we'll just have to confirm that. The times listed there on the various time zones are on the slide, so we hope that you'll be able to join us. Next slide. On behalf of all of our presenters, we want to thank you all for participating on today's webinar. Please join me on thanking the presenters, IBP, the WHO, and all the other stakeholders who've made today's webinar possible. For further information, please feel free to contact Rebecca Gormley, who's coordinating this whole webinar series, by phone or by email there. I will now ask Kerrigan once again to join us and to close our meeting in a good way. Kerrigan?
Hi, so I'm just going to keep this nice and sweet and short for you. So in closing, I'd like to thank you for all coming to today's webinar. I hope you walk away with insight and new knowledge to share with others. As we move on with our day, I pray that we keep our minds and hearts open to whatever may come across our path. Miigwech, 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 miigwech.
I can't wait to get back to Toronto.